Hey, good afternoon, everyone. We're with New York City Health and Hospitals. I'm Shahran Haider. I lead Enterprise Information Management for the Data and Analytics Group, and want to hand it over to Albana.
Hi, everyone. My name is Albana Theka, and I am a Senior Director for Data and Analytics at New York City Health and Hospitals, and I lead the Financial Sustainability Analytics Core. So just a little bit about who we are. New York City Health and Hospitals is the largest public health system in the nation, with 11 acute care hospitals, 5 post-acute care long-term facilities, and more than 70 locations across the 5 New York City boroughs. We serve more than 1.4 million New Yorkers and have more than 50,000 employees. Our mission is to deliver high-quality healthcare services to all New Yorkers with compassion, dignity, and respect, regardless of income, gender identity, immigration status, or ability to pay. Having this mission means that we serve some of the most vulnerable population in New York City, and that includes people experiencing homelessness. And today we want to share with you what the data and analytics team is doing to make patient care better and faster. But before we do that, I want to take a little bit of time and talk to you about the homelessness problem in New York City. In recent years, homelessness in New York has reached the highest level since the Great Depression of 1930. And according to the Coalition for Homelessness, a New York City-based nonprofit organization, over the course of 2022, more than 100,000 different homeless adults and children slept in the New York City Department of Homelessness Services shelter system. And this includes more than 30,000 homeless children. So what are some of the causes that are contributing to these? Particularly families, is lack of affordable housing, eviction, overcrowded housing, domestic violence, job loss, and lots of other contributing factors. But compared to homeless families, the single adults have the highest rates of serious mental illness, addiction disorders, and other severe health problems. And New York is doing something about it, and it starts with our leaders. Mayor Adams is undertaking a historic effort to provide healthcare to all New Yorkers experiencing homelessness, and the administration is working hard in collaboration with state and federal partners to allow New Yorkers who have spent more than 7 days in the New York City Department of Homelessness Services shelter system to become eligible for free, comprehensive healthcare services through a specialized network of providers and care management. So this is the first, New York City is the first city in the country to provide this level of care and support for its residents. And New York City Health and Hospitals is at the forefront of this initiative. We want to change the game when it comes to this population because it is beneficial and cost-effective. However, there are many challenges along the way, and we all know how complicated and cumbersome the healthcare system is in the United States. And let's say you need to go to a doctor, and you can either call or make an appointment online through your phone or other applications, and you will have to fill out various forms, either in person or online, and then you can see a doctor, hopefully is your primary care physician, but you also need to have health insurance, otherwise you end up paying a huge bill. And even if you have health insurance, there are a set of steps that the care teams have to take to document and make sure that the insurance is paying for your care and for the care that you received. So let's say you have a dedicated primary care physician, but all of a sudden there is an emergency and you have to go to the emergency room, which it happens to be in a different hospital on location that is not part of your network. when you go to another facility, you have to start the process all over again. You have to fill out forms, you have to figure out your insurance co-payments, and many, many other steps. So all of these steps generate data for the hospitals, for physicians, for the clinical care teams, the insurance payers, and the government, who monitors quality and safety for all of its citizens. So the challenge is, how do we create a seamless experience for our patients so that it is easy to navigate the system, and so that there are no complications along the way? And so all of these transactions happen in the background without any human intervention, and avoiding possible errors along the way. So how can we make sure that data is all connected and that my patient records from hospital A make it to hospital B, to hospital C, so that all my records are available for my primary care doctor to access my full chart, my medications, my vaccinations, regardless of what facility or hospital or pharmacy I visited? And so without linking all of these data together, we cannot have a full picture of the patient and their journey. And we can't see what is happening with the patient, and we cannot provide the right treatment of care at the time of the visit. By combining the data, we want to make sure that our doctors have an accurate picture. They can make an accurate diagnosis, they have a complete picture and history of the patient. And so they can detect disease patterns based on your lifestyle changes, based on your parents' history, look at your health as a continuum and not just as a point in time. In addition, there are doctors that are specialists. So you might need to go to a specialty doctor, such as an orthopedic doctor, oncology, etc., so that these doctors can also see a full history of your primary care and be able to give you the proper treatment. In the next slide, we want to share an example of the impact of data fragmentation, which is impacted by care fragmentation. And this study comes to us from the American Journal of Managed Care. And it is showing the impact of care fragmentation on patients' health and then on cost. So on the left-hand side, you can see data from patients with high fragmented care. And on the right-hand side, you can see data for patients with less fragmented care. What is really important to point out is that the highest impact is on the cost. And so the higher the fragmented care is, the higher is the cost because of the highest number of visits to hospitals and care facilities. Now, this is one of many examples that have an impact on patient care and the level of care and the cost that is associated with the medical care in the United States. At New York City Health and Hospitals, we have put together a special population program that is carefully designed to help address the needs of patients experiencing homelessness. We want to make the experience of getting care as seamless as possible for everyone, but especially for the vulnerable population and special population. So we are considering not only their medical and behavioral health needs, but also their social, economical, lifestyle changes such as food, transportation, long-term care, hospice, and of course, housing, which is one of the main contributing factors of homelessness. We will be able to use analytics and identify these patients. We will engage with them where they are. We will seek to understand their social needs, and we will guide them to other programs and services that will help these individuals get integrated in the community. And the program has called out two main goals that we have to address from a data and analytics perspective. The first is to reduce or eliminate barriers to data sharing. And the second one is to make data available as close as real time as possible so that it addresses the needs of the special population just in time. This population is often in and out of the ER. Their care is unpredictable. So if we want to service them and provide the resources and care needed, we need to make sure that our care team is notified immediately and quickly. Now, on the next slide, I would like everyone to meet Jesus Sera. He migrated to the United States with his father from the Dominican Republic. He became homeless at the age of 16 and ended up in 8 shelters in a period of 5 years. And eventually he was diagnosed with a behavioral health condition. Now, let's take a look and understand Jesus' journey. He lives in a shelter, which means he does not have privacy or a quiet space. So he has many sleepless nights, being in a shelter, and he starts hearing voices. So he needs to see a doctor. He does not know where to go or how to get there. He does not have any money, but like every other person, he eventually ends up in the emergency room because it is closest to him. And he's seen by a doctor that diagnoses him with a behavioral health condition. He's prescribed medication, but he cannot afford it. And he does not have health insurance or income, so he decides not to do anything about it. Now, Jesus is sick and tired of the shelter system, and he wants to have his own home, but he cannot afford one, and he does not know how to find affordable housing. So he is stuck, and his behavioral health condition perpetuates. Now, New York City Health and Hospitals already has a housing program for people that qualify for housing, but Jesus does not know anything about it. And he does not know that he has to fill out forms and talk to a coordinator so that they can guide him through the process. Now, in the past year, the data and analytics teams have worked closely with business stakeholders in the Office of Managed Care, Population Health, many clinicians throughout the organization to create a comprehensive program for this initiative. But to make this program successful, we needed to involve many external partners in this process. And the boxes in the bottom represent agencies that collect information about Jesus and other patients like him that need to be collected and shared across all of these agencies. So, for example, we have DHS, the Department of Homeless Services. We have the Department of Health. We have our Department of Social Services and Human Resource Administration, who helps with assigning various health payers to a population that needs it. We have our managed care payers, which enroll these patients in their plans. We have interest from various doctors and clinicians, our ERs and other hospitals who are looking for patient information on the special population. In addition, New York City Health and Hospitals needs this information to coordinate care. And then we also have CMS, the Center for Medicaid and Medicare, where we have to report data for quality and safety on our operations. So Health and Hospitals is at the center of it all. And we have to take responsibility to build this program and so that we can manage and deliver care for the special population, which means that we have to somehow figure out a way to collect data from all of these agencies that are happening real time so that we can help these patients as close to real time as possible. And so we've encountered many challenges along the way that we are working to overcome. So for example, there is no easy way to share data across all the agencies. All these agencies work with different systems. We know that data comes in different types, fields, columns, different formats, and it takes too long to transfer. It is not automated. And so, it does take a long time to reconcile all of these different data sources in the same data format. So what this means is that it is more difficult to do analytics on this data, as there are many data issues which in turn impact not only the way that we provide analytics, but also the level of care. And so the patient is that person who is impacted by if we don't do all of this and if we do not resolve our data problems. And our doctors do not have a complete view of the patient and cannot provide the care that they need to provide. And this is why we are here today to show you all how we at New York City Health and Hospitals are tackling some of these challenges and some of the solutions and creative ways that we have put in place to improve the patient journey by addressing these challenges. And Shahran will talk more about that.
Albana, thank you. I think when you guys look at all these different challenges that Albana pointed out, the mission that we're trying to carry out, which is for the special populations, these people that are the most vulnerable in the city, we have a tall order in front of us. And if we were talking about this 6 months ago, we basically wouldn't have been able to tell you, anything much other than the fact that we have, these problems, but we don't really know how to solve them. But what we want to start with first is telling you a little bit about the idea that we had, about how we wanted to go about solving this problem. So think about Google Docs, right? When we think about Google Docs, if we want to send someone a document or a spreadsheet or an image or whatever it might be, we basically just send them a link, right? We send them a link, depending on whether we want to set up their ability to edit what we send them or just read abilities, they can do that. We've basically enabled the ability to share something without having to physically move the file or the specific PDF or document or whatever it is that we want to share with them. Now, the concept was, what if we could do this with patient data? Why do we have to move this from point A to point B to point C or whatever through all these different agencies? Is there a way for us to just take what we're looking at from a patient data standpoint, from the standpoint of these are the members that are going to care at this hospital, at this clinic, at this urgent care, they're showing up at this shelter. Is there a way for us to exchange all this information or share all this information without having to physically move it from agency to agency and organization to organization? So that was the concept. Now, we also all know that's not possible in every single instance. There are cases when data has to move from point to point. And in those cases, we would automate the process as much as possible. So the overall idea was we would make a bidirectional data exchange because we want to bring data into New York City Health and Hospitals for various purposes. Care management has to use it, population health has to use it, finance has to understand how much it's costing for us to provide the service, deliver the service. The care and quality team has to understand the care gaps so that we can address what those issues are and transfer the information to the right care coordinators so they can take the right interventions and help ensure that the chronic conditions and other serious issues that may be occurring with the patients are being addressed in a timely manner. So all of these points of the patient journey that Albana talked about, we want to get that information as quickly as possible, meaning that we want to automate. And because we're talking about the need for working with sensitive information, essentially patient data, data related to people's mental health conditions, data related to the specific clinical issues that they might be having. We are talking about very private, very confidential, very sensitive data. So we would need to build in security and governance and auditability and traceability and compliance and regulations from the very beginning. We would have to understand what those things were, and we would have to build this into the solution. So this was just the idea at this point in time. Before we even started the project, the thinking was, what do we share with our business owners in terms of how we're going to solve this massive problem of trying to exchange data across all these different organizations. So we started with this idea. I want to tell you a little bit about the approach that we used to actually start chipping away at this problem. As you can imagine, it's a multi-year journey of trying to solve this problem. But it starts with, like they say, journey of 1,000 miles starts with a single step. And what we did was we selected one small manageable use case with one single partner that Health and Hospitals had, or does have actually, MetroPlus, which is a payer. And we decided to start with files that were already coming into Health and Hospitals and were already being used for different purposes. So managed care was using them, population health was using them, our care gaps team, finance teams were looking at them. And so the question was, well, how can we take something that's existing and how can we improve that process? So, the win-win situation for the company that was sending us the data, which was MetroPlus, and the consumers on our side, these different departments, was that we told them, you guys don't have to change a thing. From the production standpoint, send exactly what you're sending. From the consumption standpoint, let us understand how you use the data, and we'll take care of the heavy lifting and the transformation in the middle. That was the approach. Obviously, for them, it was like, okay, you're going to make our lives easier, so let's go forward with the solution. The other thing that we really looked at was, how can we leverage in-house technology? So luckily, we were using Snowflake already. That was the system or the software on which we built our enterprise data platform, which I'll talk about a little bit later. And the question was, well, how can we build these data exchange capabilities on top of it, leveraging what we already have? So I can tell anyone that's been trying to shop around for a data hub or a data mesh or a data fabric or any one of those solutions, there really isn't something like that you can buy off the shelf on the market. It just doesn't exist. But it was great that we already had Snowflake. Snowflake has a bunch of different capabilities that we could use to address the data sharing, the security, the automation, and all these different features that we wanted to build into this solution. The other most important point was making sure that the right people were engaged right from the beginning. This is not an initiative that you want to embark on without securing the highest level of support all the way across the different organizations that need to work together to do this. So we started with our chief data officer. We worked with the CIO of our partner. We engaged the security and compliance teams at the highest level, the chief compliance officers and the chief information security officers of both organizations, so Health and Hospitals, as well as MetroPlus. And we made sure all the SMEs and the business owners that would actually use this data were also part of that conversation. So once they understood what we were trying to do and what problem it would solve, which ultimately was deliver better care at lower costs to this especially vulnerable population, they bought in. So that was our approach. That's how we started. So I wanted to talk a little bit more about the single payer that we started, that we wanted to address this small manageable use case. When we dug into the current state and tried to understand how is this really working, we discovered that a single set of files related to membership data was coming into multiple departments, which makes sense because multiple departments like managed care and population health and finance, et cetera, need to use the same set of data, but they're all getting it in different ways. So for example, Sera was going out to the membership portal and downloading something. In other cases, some other the MetroPlus partner that we have was sending data to our FTP site. In other cases, they were actually emailing a set of files to another department. So basically, things were all over the place, but we're really talking about it at the core as being the same set of data that had to be moved around from different point to point. and requiring all this extra heavy lifting for the downstream consumers, which were in some cases operational departments, in some cases they were analytics departments, but they all had to do a bunch of different work in order to finally work with the data, which was essentially knowing who are the members that we need to provide our services to. So as you can imagine, that's unnecessary amount of delay in the process. It can impede care, the ability to know who we need to provide care to as quickly as possible, as Albana pointed out earlier. So this is what we wanted to solve for. And that's where the data hub came into the picture, that we want to bring in all of the information, in this case, a different set of files related to membership, and we want to distribute it. We want to take on the job of distributing that to the different consumers that exist in health and hospitals. Now, in this case, this picture is showing that the data is flowing from left to right, is going in a single direction. But the way that we wanted to build the hub was, if we needed to send data back to the payer partner, we could actually do that as well, which was one of the requirements that we had from the very beginning. This, I think, is a good way of trying to understand what the data hub actually does, because as you can imagine, this is not something that's built for the technical team or the technology team necessarily. Is built to explain to the business owners, the stakeholders of the organization, that this massive effort that we're going to spend over many, many months, in some cases years, is something that involves a lot of complexity, but we have to simplify it to explain what is it that we're actually trying to deliver and how does it make things better. So the first part of this picture deals with data ingestion, and data ingestion basically covers a couple of things. So first, it includes the data load pipelines, which are the components that extract data from our payer partner. Of course, the pipelines are automated. So when new data lands, the scripts are triggered and automatically they start moving data into Snowflake. Now, when we come to the data processing and storage layer, we have a number of different things going on. So first of all, role-based security, as we talked about, which is extremely important to make sure that people that need access to PHI data get it, the people that don't need access to it don't get it, but we're really operating on the same set of data. We want to have audit and traceability rules right from the beginning. These are things that we worked out from our conversations with our security office and compliance office. That was very essential to have built in from the very beginning. And then there's a couple of components around how we stage the data and process it when it comes in the beginning from the payer partner, and then how we allow access to that same data based on the needs of different consumers downstream. A couple of quick points on how we work with the data in the staging layer. So as you guys can imagine, and something that Albana pointed out before, that when we work with different agencies, the same copy of data, like if membership data is coming from the Department of Health, and then we're getting data about those members from the Department of Housing, the homeless shelters, et cetera, they may have John Smith or hesus Sera in their system with the same name and the same information, but they will have it in different formats. Now, what we could have done is we could have attempted to create a common format and gone to every single agency and said, hey, can you send us data, with this set of columns in this exact same format, and you send it to us in this frequency, and so on and so forth, every single time. And the logic has to be the same, the values have to be the same. And I think you can all imagine that that would have been an arduous process that would probably not be very fruitful, especially if we were trying to do something in a decent amount of time. So the concept or the techniques that we use to actually deal with this data was something called the data vault modeling approach, which basically meant that we left data as close to raw, in fact, pretty much the same as the raw format as it's coming into Snowflake. And then downstream, as we need to work with the data and transform it for various purposes for various consumers, we could do so with views that we put on top of the original data. And then the access data model is the part where we actually control how different consumers get access to that information. Now, from a data delivery standpoint, there's a lot of things happening behind the scenes, but the main components are that just like data ingestion is automated, the delivery to the downstream systems are also automated. A nice little feature that we put in that I feel is very important is the file processing acknowledgement. It's just like the little things in life that make a difference. little things in life from a data standpoint and analytics standpoint can also make a difference. So in this case, when new data lands, downstream consumers know right away that it's landed because we send them a notification. From a production standpoint, our external payer partner also knows that all the processing happened correctly, which, by the way, can often fail because, formats change or a file is missing because on their side, they're doing things manually at this point in time, right? So having that acknowledgement makes a difference. And then, of course, there's the scheduler from a notification standpoint, or actually a monitoring standpoint to know when new data is coming in so that we can provide these notifications. So those are the key features from a overall component perspective. But I wanted to talk a little bit about the data platform architecture before we had the data hub, because as I noted, we wanted to leverage as much as what we had before so we could avoid going out and shopping for a different solution for a number of different purposes. Obviously, there's a heavy lift involved with getting new technology. The other is having to work with legal and procurement and all those different teams, which are necessary. But if you can avoid it, you want to avoid it because it really lengthens that process. So this is what the platform architecture looked like before the data hub. We have a 3-tier database architecture with data coming in from a staging database into the staging database initially from mostly in-house systems. And that's using standard ETL or change data capture technologies. And then we bring data into our curated layer. The reason for that is we want to have a place where we can enable research and exploration and keep data in as close to the raw format as possible, because at this point in time, we're not really sure what we want to do with it. We haven't really defined the requirements for specific reports or dashboards or AI ML solutions that need to receive the data a certain way. So basically, we've kept it as close to raw as possible, but we've added some data quality rules, some cleansing to remove duplicates, to get rid of missing values, etc. And then we've standardized some naming conventions and such around the tables and columns, so it's easy to find and understand, what to do with that information. From an analytics perspective, we have more of the traditional enterprise data warehouse setup with integrated facts and dimensions. We also have the ability to support data marts. So, for example, if the behavioral health department needs to have analysis done specifically for patients that are undergoing behavioral health therapy and treatments, then we would draw out that data into specific data marts, again, with the right security around it. So only behavioral health department staff would be able to use it. And so we would be able to create that sort of solution. Obviously, aggregations for different types of metrics, reference data for things like address geocoding and diagnosis codes and procedure codes and so on. And the most important thing about all of this is that we have to have the ability to find this information. So this is one thing that we have as a guiding principle in health and hospitals, the DNA organization, that when we build data into this data platform, we have to make sure that people are able to find it. They are able to trust it. They are able to know where it came from and how it was moved into these various analytical layers. Because if we don't do that, then data becomes useless. So we have full cataloging capabilities on top of it. And that was also important as a sort of precursor to the data hub, because again, when we think about the data hub, we're going to get data from all these different external organizations, and there must be a way for people to understand what data exists, what is available, what can be done with it, and then if they have the proper authorization and security available to them, then we can give them access and they can do the appropriate work that they need to do with that information. So from a data hub standpoint, what we've done is, based on this same architecture, we've added some of the components that you see here in orange. We have connections now to external partners that we're bringing in through a variety of different ways, but the preferred approach is through AWS S3. We bring it into the staging area. And then, as I mentioned before, there's a number of different sort of areas in the curated database, which involves, in this case, the standardization schema and the access schema. I want to talk a little bit about the standardization schema. So as you can imagine, again, if we're working with multiple payers or multiple insurance companies, every single one of them has a different format when it comes to membership data, claims data, plan data, provider data, et cetera. And you would think that we would all be following the same common format in the healthcare industry. But so far, that doesn't really happen in practice. So what we ended up doing is we use the data vault modeling approach to make sure we can bring in data in as close to the raw format as possible, as quickly as possible. But at some point, we have to standardize that, right? So when a downstream department, like the managed care department or the population health department, is looking for information, they don't have to deal with format A from pair A and format B from pair B and format C from pair C and so on and so forth. So you can understand why that would be a problem, because it creates unnecessary steps from a operational perspective or a care perspective to have to deal with these different formats, when it would be nice if they could actually see it all in one single sort of view. So we create common views on top of the membership data. We can do the same thing for other types of information, such as provider data or claims data and plan data and so on. So we have the ability to standardize that, and then different parties downstream can pick up what they need to use, again, provided that they have the proper authorization, and we give them that based on role-based security options in Snowflake. The final component here, and probably one of the most important, I'll focus on the part about data sharing back to external partners. And there's really three parts, three ways that we can send data or make data available back to our external partners. Ideally, if both parties, so health and hospitals and our external partner, so let's say in this case, MetroPlus has Snowflake accounts, then what we can do is essentially have this Google Docs-like effect. We're talking about one database, which is updated based on whatever operations and frequency that we have. And then at that same time, the external partner also has access to that information, and they can write back or edit data in that database if we set it up that way, and if both parties have Snowflake. The other option is if one party has Snowflake, which in this case is us at New York City Health and Hospitals, but the other party does not, we can set up something called a Snowflake reader account, where they can see the updates that we're making to our data as soon as we make it, but they cannot write back or edit to that database. But that is still beneficial because they have access to the information as quickly as possible, which from a care perspective has massive implications, because we're talking about, again, a very vulnerable population that has complex chronic conditions, and not knowing when someone became a member so we can provide care to them, or when someone showed up at the shelter, or when someone's going to the ER, and not being able to send that message over to our care coordinator can literally mean life or death in certain situations. So we want to be able to pass that information on as quickly as possible. And then the third option is to send data back through AWS S3 and create separate buckets for these external partners based on, again, role-based security, which is intrinsic to this entire setup and this entire architecture. I want to tell you a little bit about the results that we're seeing from this solution that we are seeing today as a result of having spent many, many months working on the strategy and the approach and the architecture and the development. So this is what the data distribution looked like prior to the data hub. It's quite an eye chart, so please don't try to read it. There's really just three key takeaways here. So first, as you can see with these little people icons, those represent parts of the process that are manual. So there's a lot of manual effort, which adds time, that it can add sort of error into the process when things are done differently. The second thing that it means is because it's manual and because it's person dependent, let's say if Lucy, who's in charge of this process, decided to go on vacation, and Susan, who's her backup, also wants to go on vacation, we would have to say, hey, Susan, you can go on vacation because then this whole process is going to really slow down. So that's not an option, right? And that's not a thing that we want to be able to say to Susan. The third thing is, even when this process worked exactly as it was designed, membership data would only show up to the downstream consumers, which in this case was our roster, the group that's accessing member data out of our clinical workflow system, and data needed for population health analytics and so on. They would have to wait 5 to 7 days before it got there because of all these manual steps in the process. So as you can imagine, that's not ideal. So 5 to 7 days before we know who's actually a member in our special populations program and being able to do the requisite clinical and care coordination activities for those members. So that's how things were working before, 5 to 7 days, which is a very long time, as you can imagine. Now, this is what things look like from a design perspective. We talked about data ingestion, data processing, and standardization, and data delivery. And when we look at all these components, fully automated end-to-end, so data shows up from the external partner, Metro Plus, in the file delivery location, and then it flows through end-to-end with the full security controls around it, full security, audit, and traceability. And then we've got this standardization happening on the data. We've got all the rules applied around what the logic needs to be in order to transform into some other type of value that the business has specified for us. And end-to-end, this data delivery time has been reduced from 5 days to 5 minutes. So that's a massive jump or gain in performance. And the other benefit is everyone at health and hospitals, no matter what department it is, if they need to use a copy of that same core data, which in this case is membership information, they get that data at the same time. So this is what's running in production right now. And this is the solution that we had intended to design and deliver for our business stakeholders. So I want to talk a little bit about the lessons that we've learned along the way. I want to give it back to Albana to talk a little bit about how we started that journey. So back to you, Albana.
Yeah, there's lots of lessons and takeaways that we learned along the way. And what also is important to mention is that Shahran and I partnered through this journey along the way, him from an engineering perspective and me from an analytics perspective, and we partnered with the business during this journey. And I think it's very important for teams within data and analytics to partner and collaborate together. And show that partnership. But the most important thing is that, and the funny thing is that no one asks for a data hub or a data mesh or a data lake or a data fabric or any other terminology that we use in data and analytics. That these are all things that we as data leaders work with and come up with solutions for the business. And to be honest, the first time that we went to the business with this concept of the data hub, we did not succeed. They did not understand what we were trying to do, although it was very clear in our minds that this was important and it was very much needed for the organization. So we tried a different approach. And the second time, we made sure that we addressed the problem. And the problem is, how do we get care to our patients faster and in a better way so that there is comprehensive care for our patients? And this was the business problem. And the second time around, they truly understood what we were trying to convey, and we got support. But it was a journey that we had to learn the hard way.
Yeah, it took a lot of work, and it took a lot of involving the right people, as we spoke about in the beginning. Have to involve compliance and security from the start. We're talking about a healthcare data, highly sensitive, highly confidential. So that's something that that we made sure that we were going to do from the very beginning, in involving the chief compliance officer, the chief security officers from both organizations. And in fact, when we showed that process flow that I just showed you guys a couple of slides ago, it was pretty evident to them that it was not something that was sustainable or scalable or even very safe, if you think about it, because things were being emailed. Once data landed and was going through these different steps, there was no traceability around who was using it for what purpose and so on. We can control all of that through the solution that we just showed you. Start with the end in mind. Massive problem, massive implications, makes a big difference to the people that we're trying to take care of, our patients. But we can't bite off, the whole thing at one time. So we started small, which was this one use case. And now that we have this one solution working for one partner, in fact, actually, last week we deployed another partner, and then we've got 4 other payer partners that we're going to complete over the next 5 months or so. So we started small, we got the buy-in, we showed the results, 5 days to 5 minutes. So now we have the support that we need to keep going. keep business and technical stakeholders engaged throughout the process. So this is a mistake that I think I personally made in the past. I think some or many data and analytics leaders tend to do, which is we get excited about trying to help and solve a big problem. And then we pitch an idea, we get the support, and then we kind of disappear for 6 months and come back and say, here's what we built, right? But that doesn't work, because I can tell you, like, even in the conversation that we have today, sometimes people still ask, hey, what's the data hub again? Right? Because it's a complicated thing. So we have to keep explaining, we have to show the process, and we have to get the feedback. It also helps when trying to make progress. So one example I'll give you guys is earlier in the project, when we were first trying to deploy the first partner, we got stuck because we were unable to set up the security configuration properly to access the data. And the CISO from our external partner was on the call. This is our regular external stakeholder meeting. And he said, what do you need? And I said, we basically need your team's help because we're stuck. We can't set up the right configuration. The next day, the problem was resolved only because we had the right people engaged on a regular basis. So please do that when you're trying to embark on a journey as complicated as this one. As I said, the solution is complicated. Keep simplifying it as much as possible. Don't get into the architecture necessarily, but build those simple boxes, explain what we're trying to do, how it makes a difference. That makes a huge impact. And there are times that we weren't able to do that very well, and we got lost. And that's what tends to happen in complicated solutions. And then I want to pass it back to Albana to talk about the ultimate mission, which is our guiding star, which is the reason that we do this, which is the reason that we feel good when something like this works. So back to you, Albana.
Ultimately, we definitely want to remember the mission and why we're doing all of this. Why are we spending funds, energy, and resources? And the answer is New York City Health and Hospitals is there to provide care for the patient population in New York City. And as part of that, we want to make sure that we are including everyone, not only the patients that need the care, but also the homelessness population, which truly needs our care and support. So with that, we have a really beautiful video that we want to close out with. And this is one of our many success stories in this journey. And we want to get back to Jesus and see how his journey ends. And this was something that was done in collaboration in partnership with our Housing and for Health department.
Well, I remember when I first got here, I was like, wow, I feel like home. I could go to sleep, I could wake up anytime, I could cook my meals, I could eat whatever I want. And that feeling is amazing. And I think having this, everything, a bed, a big bed compared to a twin bed in the shelter. And I think that makes me feel happy, and by feeling happy, that's improving my mental health and also my physical health. So this apartment makes me feel like I came because I'm in control. It's something that I never had before, and I have now. Even though it's small, I have something that I can say is mine. Even though I don't own it monetarily, but I'm the one in the list, so I can say, this is my apartment.
It's a great story, and it always makes me feel great when I listen to it. But yes. Thank you so much for listening to us.
Thank you guys. Thank you very much for letting us share our story.